Hey team, it's Amy, your nurse educator, and today we're going to be talking about atrial fibrillation, otherwise known as A-Fib. Remember, atrial fibrillation is caused by a disruption in the electrical pathways of the heart, specifically your right atrium. The right atrium houses your SA node, which is the primary pacemaker of the heart. The SA node sends electrical signals to both atrium down to the AV node and the bundle of His, which then distributes the signal to each of the ventricles to cause a contraction. And that contraction is what sends blood out of the heart to the rest of the body. So in A-Fib, something causes some of the electrical cells in the right atrium to become irritated. The cells in the right atrium of the heart have the unique ability to cause that contraction to occur. Now, normally the SA node is the primary pacemaker and is what directs that signal to occur. But when some of these rogue cells become irritated, they are going to try and take over control from the SA node. And that's what causes these fibrillatory waves to show up on the ECG, because there's multiple points trying to vie to take over control as the primary pacemaker in the heart. So what causes this? Well, there's two main causes. Anything that causes a decrease in oxygen to the heart, specifically around the right atrium, can cause irritation of these cells. So think of things like heart attacks, coronary artery disease, hypertension. All of those things are going to decrease blood flow to the right atrium of the heart, which again is going to cause those cells to be irritated. The second main cause of this irritation is anything that causes an increase of blood volume in the right atrium of the heart, okay? So think of things like heart failure. When you have that backup of blood that goes straight into the right atrium, what that blood does is it stretches the walls of the right atrium, and as those walls stretch, it causes those cells to become irritated, leading to atrial fibrillation. Other causes of this increase in blood volume in the right atrium include things like giving a lot of fluid, like in fluid boluses. And this is something you really need to pay attention to, especially in your elderly patients that already have a history of some type of heart disease. As that fluid is rapidly infused into the right atrium, it's going to cause that stretching, and you may see atrial fibrillation occurring, okay? So again, that irritation is what's causing those cells to each send their own signal, bypassing the SA node, down to the AV node and the rest of the electrical conduction system. And that's what gives us that irregular rhythm on our ECG monitor, okay? It sometimes takes a little bit of time to get that signal down to the ventricles to contract. Sometimes it takes a little bit longer, and that's where that irregularity occurs, okay? So now we know what A-Fib is. What do we need to do to assess A-Fib in our patients? Well, one of the first things you need to assess is the patient's heart rate. We're specifically looking for tachycardia with A-Fib. That's commonly referred to as A-Fib with RVR, rapid ventricular rate. Anytime a patient has tachycardia, it can lead to hypotension as the heart is working overtime with that increase in heart rate. So we really want to be mindful of watching the patient's heart rate. And the second thing we need to be assessing for is hypotension. In A-Fib, as those irritated cells are vying for control, that can cause a backup of blood to be sitting in the right atrium, okay? And this can lead to up to a 20% loss in the cardiac output of the right atrium, okay? And that can ultimately lead to hypotension and the patient becoming unstable. So we really want to make sure that we're watching for hypotension in these patients. The third thing we need to be assessing for is the patient's neurostatus. As that blood is sitting in the right atrium, it can sometimes coagulate. As that blood is starting to coagulate, as it then finally begins to move into the right ventricle and then pumped out of the heart, that coagulated blood can go straight up to the brain and cause a stroke. Not good. So we really want to be assessing the neurostatus of any patient that has atrial fibrillation. Okay? So we know what to assess for. Now what are we going to do for our patients in A-Fib? Well, most likely they're going to be on some type of antiarrhythmic medication. This could be anything from a calcium channel blocker, beta blocker, amiodarone. We really want to have them on a medication to help calm down those irritated cells that are in the right atrium. The patient may also be on some form of an anticoagulant. Again, trying to prevent that stroke from occurring, as that blood can sometimes sit in the right atrium. If the patient becomes unstable, meaning their blood pressure drops, they could be a candidate for a cardioversion. Sometimes before we do a cardioversion, the provider will do a TEE, which is a procedure where they put a scope down the esophagus, allowing them to look into the right atrium of the heart to see if there's any clots before doing a cardioversion. A cardioversion is where we bring the defibrillator into the room, attach it to the patient, and shock the patient even though they have a pulse. That shocking can sometimes send the clot up into the brain. So we want to make sure that there's no clots before we do that. And the last intervention that the providers can do is called an ablation. And that's where they go in as a procedure and they're cauterizing these irritated cells so that the SA node can regain control. All right, so that was a crash course in atrial fibrillation. Be sure to click that subscribe button so you don't miss any more of my videos, and I'll see you next time. Have a good one.